Hi, thanks for stopping by to take a look at this presentation. My name is James Schlotzhauer, and this presentation is part of my coursework at American Military University. Specifically, this is for Psych 514, Disaster Psychology, with Dr. Thomas King. And this is a presentation on trauma-related psychiatric disorders, specifically ASD and PTSD. We're going to be looking at a number of things in this presentation, including, and basically what I'm hoping to do is to provide a clear research-based overview using the DSM-5 and trauma psychology literature, so we can better understand how trauma can shape mental health outcomes and how communities can respond more effectively. Now, before we proceed, I want to take a second to kind of give an overview of what to expect in today's presentation. And mostly, we're going to be talking about, as I said, acute stress disorder and post-traumatic stress disorder, also referred to as ASD and PTSD, as well as risk and protective factors, community impacts, co-occurring disorders, and stigma amongst first responders. These two things are very, very similar, and they are directly related in many, many ways, but they're not entirely congruent. And we're going to get into the distinguishing factors, having an idea of what distinguishes them, how they can be diagnosed, and then hopefully gaining an understanding of how these factors can help service providers and clinicians perhaps understand vulnerability versus resilience, reducing the vulnerability and increasing the resilience. And then trying to better inform both preparation for post-traumatic events and then better supporting interventions subsequent to traumatic events. Then we're going to describe the impact of trauma, as I said, on both the individual and community levels, because it is surprising how deeply trauma can in fact affect communities on all sorts of levels. And we're going to be drawing most of this from research on mass trauma events, like work summarized by Neri, Nandi, and Galea on post-disaster PTSD. Then we'll do some psychological aftermath described by Tremonton and Halpern in the context of terrorism. And then also, I'm going to base my discussion on common occurring disorders and specifically to treatment-seeking behaviors among first responders, using insights from Schlossberg and Killarney and Schlossberg's work on police and emergency personnel. Dr. King, I'm going to make this as quick and painless. I know you have dozens of these to look at, but I'll go as quickly as I can through these. So acute stress disorder is where we're going to start. As I said, it's classified in the DSM as a stressor-related disorder. It occurs usually in the first month following exposure to a traumatic event. Those traumatic events, by the way, we should get into that a little bit. Trauma is not really the event itself. It's how it's held and processed by the individual who experiences it, right? So basically, starting with ASD, the onset of ASD or the stress and symptoms of this disorder usually occur within 3 days post the event itself. The symptoms have to last at least 3 days and up to a month. And the DSM requires 5 of 9 or more symptoms from 5 categories. Those categories are intrusion, negative mood, disassociation, avoidance, and arousal. The symptoms can include distressing memories, flashbacks, inability to experience positive emotions, depersonalization, sleep disturbances, hypervigilance, things like that. It is interesting that this disorder used to require disassociation, although it doesn't necessarily. It's not required for a diagnosis any longer, but it is often an evident or manifested symptom. Many people recover naturally. ASD is and can kind of work through this in that initial relatively brief period, but it's clinically significant because it signals an immediate psychological distress and increases the likelihood of later developing PTSD. Early recognition allows clinicians to intervene in ways that may prevent more chronic impairment. Now, post-traumatic stress disorder, or PTSD, on the other hand, develops, again, when trauma-related symptoms will develop or persist more than a month, and cause significant distress or impairment. The DSM-5 organizes PTSD symptoms into 4 clusters: intrusion, avoidance, negative alterations in cognition and mood, and alterations in arousal and reactivity. Examples of these symptoms can include recurrent intrusive memories and nightmares, efforts to avoid the reminders of the traumatic event. Again, I think it's so important to stress that it's not the event that's traumatic, it's the processing and what occurs within the psyche that makes it traumatic. But the effect of this event needs to persist for more than a month and can, in fact, persist for years. While ASD captures the immediate aftermath, PTSD is a more longer-lasting disruption of the nervous system and psychological functioning. And research on veterans, like Kinney's research of PTSD in returning Iraq and Afghanistan veterans, shows that PTSD can be chronic and affects occupational and social functioning for years. Similarly, Neria and colleagues' systemic review of disaster-related PTSD shows that large-scale traumatic events, like the World Trade Center event on 9/11, can lead to widespread long-term patterns of PTSD among survivors and responders. As I said, it doesn't always emerge immediately. It can develop months or even years after the event, and especially, and this is really important, when there's cumulative trauma or delayed reactions are involved. First responders are going to have that cumulative trauma that can just sort of drip like water can erode rock, and it'll continue to drip and increase and escalate over time. As the frame shows right here, we've got symptoms, duration, symptom clusters, and it's often chronic without treatment. In this relatively simplistic slide, we've got real simple distinguishing factors between ASD and PTSD. They do share many features, but the primary distinction, again, is the duration of symptoms. ASD occurs 3 days to 1 month after trauma. PTSD lasts more than a month. And again, in earlier DSM versions, disassociation was emphasized heavily in ASD. Not anymore, but it does still manifest. And it can be a predictor, and ASD, this is a really important thing, it can be a predictor of PTSD, but not everyone with ASD goes on to develop PTSD. There's research that's basically summarized in our class materials, highlighting that early symptoms can gradually fade in ASD, or they can persist and intensify. And we're going to get into some of the individual factors, protective factors, and avenues of or ideas of propensity towards PTSD in future slides. But this is a real simplistic slide before we get into the more detailed next slide. So this graphic is much more detailed than the prior, and basically it goes through both the timelines and the required symptoms for each diagnosis, and how it does show how, while they are somewhat congruent with one another, they're not exactly the same. ASD, again, 3 days to a month post-trauma. PTSD, a month past, and the onset can be delayed, but it can go much, much farther than that. Diagnostic is the presence of 9 or more symptoms from 5 categories on ASD. PTSD is much more, there's categorical clustering that the symptoms have to be drawn from. You need one, it's almost like a Chinese, the old-fashioned Chinese menu where it's one from column A, one from column B. And in this case, it's one from, or it's at least one from 4 different clusters. Basically, the reason that this is important, and this is a good slide to slow down on if you want to take a look at it, and get into more detail. But the reason this is important is ASD can often lead into PTSD and can help inform effective interventions. So the risk factors for ASD and PTSD are similar for both. And research indicates that certain risk factors actually increase the likelihood that trauma exposure is going to lead to AESD or PTSD. The Institute of Medicine's report on PTSD outlines several of the most robust predictors, which I've included 5 of them there. They include the severity and the intensity of the trauma, direct combat exposure, physical injury, witnessing death, etc. Experiencing sexual assault is very high on the list. Cumulative life stress, meaning the total amount of adversity experienced before and after the trauma is another strong predictor. Lack of social support is one of the most consistently identified risk factors, as survivors who feel isolated or unsupported are more vulnerable to prolonged psychological distress, and that's common to the human condition. The impact of social interaction and strength is felt throughout our lifetime through developmental phases, through identity development, and here as well, it's no different. Additionally, demographic variables can include lower economic. I'm trying to speak quickly, but they include lower socioeconomic status, lower education, and honestly, being female for some reason has some sort of confers a statistically higher risk in many studies. It's not just the objective severity of the event, but it's also the subjective experience, again, of the event itself. It's not how the event, but it's how it's processed. All of these can have a very significant impact on individual resilience, and these factors can increase risk for the development of ASD and PTSD. And as I said on the earlier slide, we have risk factors, but we also have protective factors as well. Protective factors are crucial in determining whether or not trauma leads to long-term symptoms. Again, high social support, strong social support, hugely protective and beneficial prior to the experience of aversive events. Being prepared and being trained for these, knowing what to expect and how to handle them is a big deal. Strong coping skills, supportive family relationships, community ties, all these sorts of things are very positive protective factors. And then stable post-trauma environments like safe housing, access to healthcare, consistent routines. This also aids recovery. Trauma psychology literature also emphasizes natural human resistance that people, when they experience temporary stress. And these reactions will gradually, even with ASD, will gradually subside without becoming chronic. The protective factors highlight the importance of community resources, especially afterwards. Beforehand, of course, to support the resilience, and afterwards for early and sustainable intervention. But protective factors are very important in determining whether and how trauma will manifest itself with those suffering from PTSD. And now continuing the thoughts from the prior 2 slides of both protective and risk factors. Why are these things important? Well, they are essential for assessing and having an accurate psychological assessment. You have to be able to assess not only the symptoms, but the context surrounding the trauma. So for example, somebody with strong social support and no previous trauma can exhibit short-term stress reactions that resolve naturally, while someone with prior trauma or limited support may be at higher risk for developing PTSD. Knowledge of these factors can help clinicians determine whether symptoms reflect expected human responses, being the normal reaction to sometimes horrific events, or emerging psychopathology that requires intervention. And as emphasized in the DSM-5 and in the trauma research, effective assessment also requires evaluating cultural factors. That's huge. That was revolutionary almost in the DSM-5. Cultural factors, coping strategies, environmental stressors, these things are key to valid diagnosis and intervention design. By integrating these considerations, you can create individualized treatment plans and identify high-risk individuals early and avoid misdiagnoses. The context-sensitive approach is especially important when assessing first responders, veterans, and disaster survivors. Their environments and how they process these events is often very different from citizens or civilians who don't often, not only do they not often experience them, but they very rarely consider them. Our assignment requires a certain number of images. This is just an image that I using, and this will be in the credits as well, using AI. I created this to try to reflect the balance of risk factors against protective factors when preparing for traumatic resilience. If you look at this, imagine that this is representative of one simple individual, right? You've got the prior exposure, you've got prior traumas weighing down on one side, and the shields represent the social bonds, the resources one may have, the training one may be given, and they balance each other out. It's important to understand and to balance these risk factors against the protective factors when you're preparing for traumatic resilience, especially in first response. Now, as I mentioned in the overview, you have effects on individuals, you have effects on communities, and at that intersection, you also have effects on first responders. So I'm going to start here first with the effects on individuals. These are pretty straightforward. You've got hyperarousal sleep disturbance. These are examples of effects: emotional numbing, functional impairment in work and family life, flashbacks and re-experiencing. These are very common effects on individuals who have been faced with traumatic experiences. Research from Kinney's article on returning veterans that highlights a toll of prolonged hypervigilance and re-experiencing symptoms. Trauma psychology literature also emphasizes that many survivors, both of military conflict and of both natural and human-made disaster, can struggle with guilt, fear, distorted beliefs about themselves and the world. These are not. It's important to know, though, that these are not signs of weaknesses necessarily. They are evidence of the brain and body's efforts to adapt to overwhelming stress. And so these are symptomatic, or these are symptoms of the body's attempt to overcome that stress. And it's not weakness. It's the body's attempt to heal and, perhaps more importantly, manage itself. But with that said, there are co-occurring disorders with PTSD that exacerbate issues and create a much more complex clinical analysis. Substance abuse disorders are particularly common, and many people use alcohol or drugs to manage intrusive memories, emotional pain, depression, etc. Depression and anxiety itself frequently accompanies trauma-related disorders and can intensify functional impairment. There is research from EMDR showing that, or highlighting that trauma's role in various other disorders like chronic pain and even psychotic symptoms exist. And that, by the way, the psychoses, I'm not saying that trauma causes psychoses. What I am saying, though, is that psychosis is oftentimes a comorbid disorder that does manifest with PTSD. Trauma exposure is also associated with difficulties regulating emotions, interpersonal conflict, increased risk of suicidal behaviors, and these co-occurring conditions can make assessment and treatment much more challenging. Recognizing these overlaps, as shown in this Venn diagram here, is essential for providing a comprehensive treatment and preventing symptoms from worsening over time. I'm noticing our presentation is getting a bit long, and I want to try to hit a number of things. So I'm going to kind of breeze through this one a little bit more quickly than I might otherwise like, especially to get to the next slide. But the effects on communities are oftentimes as strong, if not stronger, of the effects on the victims of trauma. These things include many things, but I've distilled them down to four major things here on this slide. Collective distress, which is huge, where members of a society lose their sense of safety, their sense of well-being. There's economic and social strain, very clearly strain on emergency systems, and then increased healthcare demand, which can be very, very detrimental to those communities with healthcare systems that are already stretched. This slide gets much more detail into the broad scale of trauma effects on communities and trauma-informed community building. I stumbled across this image in my research and I loved it. It's not directly cited in the upcoming reference list, but it was published by Bridge Housing Corporation and Health Equity Institute at San Francisco State University. It is important that I credit them with this. But it reflects a trauma-informed community building model, or TICB, which is an innovative model for community resilience, responding to challenges faced by communities prior to trauma, but also after disaster. So it emphasizes safety, consistency, relationship building, and reducing stress as foundational for engagement. Rather than expecting traditional resident participation in environments shaped by violence, displacement, or poverty, TICB prioritized meeting immediate needs, creating predictable routines, fostering supportive connections so that they have the stability, that the community has the stability and the resilience needed to heal with everyday traumas, and then eventually also when the irregular large-scale natural disaster, human-made trauma, human-made disaster visits that community. We are running short on time. This graphic is really terrific, and I would suggest, if you have time, to stop and take a look at it in a little bit more depth. These sorts of things, they do extend to all sorts of things beyond the individual, like healthcare systems, schools, workplaces, emergency services, and it reinforces that trauma is not just an individual experience, but a communal one. Now, at the intersection of community and individual effects to traumatic events are first responders. They are individuals. They're also part of the government. They're also part of the systems that people rely upon to face these events. And that includes military, National Guard, police, fire. And these men and women in these services also hold themselves to a very high standard of strength, honor, and pride. And that is representative of this image here. But this image, just if you look at this image and the depth of pride that these individuals are exuding, and actually I think are inculcating within themselves, it's often an unfair and unsustainable image. And frankly, it underscores the stigma that many can feel about receiving mental health treatment or mental health support that creates significant barriers to both help and resilience. Mental health struggles among first responders are common and understandable given the nature of their work. It's important to remember, however, that seeking help should be seen as a sign of professionalism, not weakness. And perhaps if it's framed that way, as opposed to any other number of ways it could be framed, that perhaps these individuals may be a little bit more receptive to receiving assistance. And in this slide, we go from the sort of overview of that one individual image into more detail about stigma of first responders. It can be one of the greatest barriers preventing first responders from accessing care. And then their professional, oftentimes, first responder and military culture promotes a toughness, emotional control, and self-reliance image that many are afraid of breaching. In Schlotzhauer and Collarini, it's Collarini, Schlotzhauer, and Schlotzhauer, by the way, they describe how first responders can fear being perceived as weak, unfit for duty, unable to perform their jobs effectively if they admit to even struggling, even thinking about it, even talking about it. Some can worry about jeopardizing their career advancement, losing the trust of peers, and as such, many first responders would rather suppress symptoms and avoid seeking help, which then exacerbates and leads to worsening PTSD, burnout, or even substance abuse. Now, reducing stigma requires organizational change, supportive leadership, peer support programs, and the normalization of seeking help as part of maintaining a fitness for duty that I believe needs to be internally motivated and removed from the fear of external judgment. So basically, these four things here are everything I just kind of rambled it very, very quickly. Stoic culture, fear of appearing weak, concerns about job fitness, and then leading to the underreporting of symptoms. It's a real issue. Which then brings us to the question, what do you do about it? Well, there are treatments. I don't like the term treatment, but there are management techniques. There are processes and ways that people can accept help in addressing ASD and PTSD. And basically, effective treatment it requires a comprehensive trauma-informed approach, right? It's got to be evidence-based psychotherapies like cognitive processing therapy is a huge one. Prolonged exposure, there are some issues with that in my mind. EMDR has been very strong in effectiveness in reducing PTSD symptoms. And then chapter 12 of our textbook discusses biopsychosocial models, which integrate psychotherapy with psychopharmacology when appropriate, and then includes social environmental support. Medications like SSRIs, they can help manage anxiety, depression, or sleep disturbances, while therapy addresses the underlying traumatic memories and cognitive patterns. Now, treatment also has to, however, account for co-occurring conditions and individualized needs. I can't stress that enough. Culture is hugely important to that. The individual's culture, the surrounding community in which he or she lives, social support, education, and community resources all play essential roles in discovery. And basically, most people can experience meaningful improvement when given that proper treatment and support, which is encouraging. It needs to be framed, however, sensitively. It needs to be approached with cultural humility and an openness and a curiosity of the totality of the circumstances of the individual suffering from these conditions. And I do know that this presentation has been somewhat lengthy, and I appreciate your patience and your attention. But to summarize, acute stress disorder and PTSD share many same features, but differ primarily in duration and diagnostic requirements. Risk and protective factors play critical roles in determining who develops trauma-related disorders, and then these factors also can help guide clinical assessment. Trauma affects not only individuals, but communities, especially following disasters or large-scale violent events. And co-occurring disorders are common and require integrated treatment. Finally, stigma, particularly among first responders, remains a barrier to care. And by increasing awareness, performing trauma-informed resources, and encouraging open discussions, communities can better support individuals affected by trauma. Thanks so much for your attention through this, Dr. King. I tried to make it as interesting and as brief as possible. I do appreciate your attention to it. And if you have questions or concerns, feel free to reach out. One very quick postscript, by the way, for these references. They basically represent the key scholarly and clinical sources used throughout the presentation, including the DSM and trauma psychology research by authors such as Kinney, Neria, Tremonton, Halpern, Schlossberg, and the Institute of Medicine. Images included in this presentation were found in public domain sources, and in the interest of strict compliance with American Public University Systems student AI policies, it should be noted that certain graphics, including the ASD, PTSD comparison charts, the comorbidity Venn diagrams, the scale, were generated with Google's Gemini image generation software using data research and supported by me. So all sources here have been or are intended to be cited in the APA 7 format as required by our assignment and our rules.